Continuing on with the GI tract, talking about care of the patients with stomach disorders. I just want to mention that the assessments for almost all of these diseases or suspected illnesses will be the same throughout these GI units. Chapters 44 through 47, very similar assessments. So please refer to your IGI Chapter 52 or the first 3 recorded lectures if you feel you need a refresher, or ask me if you have any questions. Primary areas of concern for the patient with a stomach disorder are going to be altered digestion, which is going to potentially lead to altered nutrition, inflammation, infection, pain. Some of the major stomach disorders that we will see are gastritis, peptic ulcer disease, and gastric cancers. Gastritis can be erosive or ulcer causing, or it can also be non-erosive. We could also categorize gastritis as acute or chronic. Acute gastritis is inflammation of the gastric mucosa or submucosa after exposure to local irritants. This is going to cause like a thickened red mucus membrane. After the irritating agent is removed, we can expect complete regeneration and healing within a few days, as long as the stomach itself, or the muscle, is not involved. We can see a full recovery. Chronic gastritis is usually patchy and diffuse inflammation of the mucosal lining. We will eventually see a decrease in the function of the parietal cells, and that's going to decrease our functionality of intrinsic factor. Intrinsic factor is what our body uses to absorb vitamin B. So by decreasing this intrinsic factor, we're going to probably be seeing pernicious anemia because of that decreased vitamin B absorption. We're going to have decreased stomach acid as well, and chronic gastritis is associated with a higher risk of gastric cancer. H. pylori or Helicobacter pylori is a gram-negative bacteria that penetrates the mucosal gel lining of the gastric epithelium. Long-term NSAID use. NSAIDs also inhibit prostaglandin production. So prostaglandins are what provide a protective mucosal barrier, and it is generally the prostaglandins are what keep the stomach from digesting itself. So when we have chronic NSAID use, those prostaglandins decrease and gives our stomach more of an opportunity to digest itself. Other risk factors in this kind of same area are going to be alcohol, coffee, caffeine, and corticosteroids. Type A chronic gastritis has been associated with the presence of antibodies to parietal cells and intrinsic factor. So kind of a combination of a lot of these things. So we're going to see that decreased vitamin B absorption causing pernicious anemia, as well as the parietal cells are going to be affected, which is what's going to cause the decrease in intrinsic factor. Type B chronic gastritis is the most common form, and that's caused by the H. pylori infection. With the H. pylori infection, so remember this is a bacterial infection, there's going to be an activation of lymphocytes and neutrophils. And then, of course, we're going to have a release of inflammatory cytokines, and that is going to be what destroys the gastric mucosa. Assessments for gastritis are going to be, we're going to probably see abdominal tenderness, bloating, nausea, vomiting, hematemesis or vomiting blood, melena. So melena is going to be that black, dark, tarry stool. dyspepsia or heartburn. And an EGD with biopsy is going to be the standard for diagnosis, especially for chronic gastritis. Nursing interventions are going to be educating about a balanced diet, regular exercise, which helps maintain peristalsis, stress reduction, limiting caffeine, chocolate, mustard and pepper, or other things that are strong or hot and spicy, avoiding alcohol and tobacco and NSAID use. Management is going to be H2 receptor blockers to block gastric secretions. Sucralfate or carafate is a mucosal barrier fortifier, and that's used to help the lining of the stomach. Antacids, anti-secretory agents like PPIs might be used to suppress gastric secretions, and these folks also might need vitamin B12 because of the decrease in intrinsic factor because of the damage to the parietal cells. Peptic ulcer formation. So this is a little picture of ulcer formation in either gastric ulcer or duodenal ulcer. It kind of explains the difference between both of them. A peptic ulcer is a mucosal lesion in the stomach or the duodenum. Peptic ulcer disease occurs when the mucosal defenses become impaired and the epithelium is no longer protected from acid and pepsin. There are 3 types of ulcers: gastric, duodenal, and a stress ulcer, but stress ulcers are much less common. Most gastric and duodenal ulcers are caused by H. pylori, which is believed to be spread through contaminated food or water. Stool, vomit, and saliva infected people may also spread it, and it's also believed to be associated with NSAID use. So the mucosa is going to break down because of the activity by cytokines and neutrophils in response to H. pylori. And also, H. pylori produces urease, and that's going to neutralize the stomach pH. The urease itself can be detected in the lab, and that can help with the confirmation of H. pylori infection. Another problem with H. pylori is that it's helical in nature, so it allows it to burrow in the mucosal layer of the stomach and keeps our immune system from detecting it. So it increases the risk for peptic and duodenal ulcers because our body can't detect it and get rid of it. NSAID use breaks down the mucosal barrier by inhibiting prostaglandins and cyclooxygenase inhibition. COX-2 inhibitors like Celebrex are less likely to cause this problem, but carry their own risks along with and could cause higher cardiac risk. Caffeine and corticosteroid use also is a problem for ulcer formation. And are obviously lifestyle changes that we could educate about. So here is this is going to be peptic ulcers. So peptic ulcers usually develop in the antrum of the stomach, usually when a break occurs in the mucosal barrier and then the acid injures the epithelium. Duodenal ulcers occur high in the duodenum and usually penetrate through the mucosa and submucosa into the muscle. Duodenal ulcers generally occur due to low pH levels in the duodenum for long periods of time. So maybe some damage to that pyloric sphincter could cause a duodenal ulcer. Stress ulcers, like I said before, are the most rare kind of ulcers, but they can occur after like a trauma or an acute medical crisis like surgery, which is oftentimes why we'll see folks in the hospital in acute care on proton pump inhibitors, usually IV. So these stress ulcers, like if a patient is NPO for surgery, they might get a stress ulcer, and these are just shallow erosions in the stomach or duodenum, and associated with long hospital stays. Complications with ulcers are hemorrhage, perforation, pyloric obstruction, and intractable disease, or disease that just won't go away and keeps coming back. Bleeding, of course, is the most serious risk. And usually if we see bleeding with peptic ulcers, we're going to see people who vomit blood. And that's going to be indicative of an upper GI bleed, which is at or above the duodenojejunal junction. If we're going to see something, if we see coffee ground emesis, that is also going to be from a gastric ulcer. Whereas if we saw melena, that's generally going to be digested blood, so blood that we'll see from lower than the duodenum in the small intestine. A perforation, if we see a perforation, that's going to be where the ulcer erodes the entire thickness of the stomach or duodenum, usually causing peritonitis. So these folks are going to be in pain. Septicemia can follow. Hypovolemic shock can occur really quickly. With a physical assessment for folks who have a peptic ulcer, they might have epigastric tenderness. If a perforation is present, they might have a really hard abdomen. We call that board-like, like a hard board-like abdomen. They might have rebound tenderness and pain. But indigestion is the most commonly reported symptom, and it's reported as sharp burning or gnawing. They might have like abdominal pressure or feel full, but they could also feel hungry. So who knows? Gastric ulcer pain is often in that epigastric region, generally left of the midline, and is aggravated when someone eats. So it gets worse when someone eats. Whereas a duodenal ulcer pain is just the opposite. So duodenal ulcer pain is to the right of or below the epigastrum, and it usually occurs an hour and a half to 3 hours after eating. And it can also wake people at night. So the way I like to think about gastric versus duodenal ulcers is I think about that like it's not the low acid isn't hitting the duodenum until it's gone through the stomach. So it has to have time to go through the stomach, and then when the pyloric sphincter opens and puts the digested food into the duodenum, that's when it's going to have low pH hitting the duodenum. So an hour and a half to 3 hours afterwards, it's going to hit that duodenum and it's going to cause some pain. Pain can be exacerbated by certain foods, of course, high acid foods, fried foods, onions, alcohol, caffeine, or NSAIDs. With peptic ulcers, if someone is nauseous and vomiting, we have to watch for fluid volume deficit. We also have to watch for that if they have a bad enough peptic ulcer that they are bleeding. We need to be paying attention as well to that fluid to the fluid volume. Watching for hypotension and orthostatic blood pressures. Gotta be careful about dizziness and potential for falls. As far as lab goes, checking for H. pylori, we can do that in blood, in breath, or in the stool are some places that you might see lab assessment of H. pylori. We're also going to have to be doing a CBC to check for anemia. Make sure that these folks aren't anemic, so looking at that hemoglobin and hematocrit. As far as imaging goes, we might see abdominal x-rays just to rule anything else out. Otherwise, an EGD is going to be the most common to look for peptic ulcers. It's also going to allow a provider to biopsy for H. pylori. Interventions are going to be pain relief. We have to eliminate that H. pylori infection, so we're going to be using antibiotics. And it's usually a cocktail of multiple antibiotics as well as some of the other medications we've talked about, like those PPIs or H2 blockers. We have to heal those ulcerations to prevent recurrence. We have to tell patients that they can't abruptly stop their PPI because of rebound proton pump activation, which is going to cause pain, but it's also going to potentially ulcerate the stomach again. Of course, educate them to exclude foods from their diet that cause discomfort, avoid bedtime snacks and tobacco and alcohol, and educate about stress relief, potentially helping. Here is a gastric ulcer. It's not a bleeding ulcer and nothing that looks malignant, but they are going to probably, this is like an EGD, and they'll probably take a sample with brush cytology or biopsy it to see, just to make sure it's not cancerous. Here are some duodenal lesions. They are those kind of white flecky things. They call them salt and pepper duodenitis. Kind of interesting. This usually responds to an acid secretion inhibitor. And here's an ulcerated duodenum. An upper GI bleed, we have to really watch this, especially for our older adult population. Blood loss from peptic ulcer disease results in high morbidity and mortality. We have to really watch fluid volume loss due to vomiting as well as bleeding. So this can lead to dehydration, of course, electrolyte imbalance. So we're going to have to educate that patient's going to need to increase fluids as long as they're not NPO, and if they are, we're going to have to be minding their IV fluid volume. They might need blood products, especially fresh frozen plasma if they are actively bleeding. They'll probably have an NG placement to get some of that blood out of their stomach, and I've never seen it done. But lavage might be possible, where a water solution is instilled and then withdrawn until the return fluid is clear or pink and doesn't have any clots. If they went in with an endoscope, they could potentially treat those bleeding ulcers and cauterize it, either with medications or heat or electricity or laser. They could also band or clamp it and actually just stop the blood that way. Interventional radiology procedures, they could go in actually through the artery and stop the blood. So that would be obviously pretty severe case of bleeding in the GI tract. So we're going to have that NG usually on, depending on the kind of NG tube we have, we'll have it either on low intermittent suction or on continuous suction. Like I said, depending on the kind of NG we have, we just have to make sure that the NG is not going to be suctioned to the wall of the gastric mucosa. If we have it on constant suction, that is a possibility, so we have to be careful with that, which is why oftentimes you'll see people on low intermittent suction. Now, if you have a Salem sump tube, that is a specific kind of NG tube, and that can be placed on low continuous suction because there's like a vent that prevents it from sticking to the side of the gastric mucosa. If you don't have a Salem sump, then you have to have an NG tube on low intermittent suction. Gastric cancer risk, H. pylori. This should be seen as a trend. So H. pylori is the greatest risk for gastric cancer. Patients who have pernicious anemia, gastric polyps, chronic atrophic gastritis, and absence of hydrochloric acid secretion, they're all 2 to 3 times more likely to develop gastric cancer. Foods that people eat can increase their risk of gastric cancer. Pickled foods, sad. Salted foods, smoked foods. Lots of processed foods, so nitrates, and then, like I said, highly salted foods, as well as diets that are low in fruit and vegetable intake. Those are all risk factors for gastric cancer. Prior gastric surgery is a risk cancer, as well as Barrett's esophagus from GERD. And Barrett's esophagus is also associated with tobacco use, both smoking tobacco and smokeless tobacco. Gastric cancer rates are twice as high in males as in females. Lowest rates, as far as geographically goes, are in North America and parts of Africa. And Eastern Asia, Europe, and South America have the highest rates. Average age for developing gastric cancer is 70. Symptoms, early gastric cancer symptoms are going to be indigestion and abdominal discomfort. In your Iggy book, 8th edition, page 1139, chart 55-6, it's called Key Features, Early versus Advanced Gastric Cancer. That's a really good table. So the advanced symptoms of gastric cancer are going to be weight loss, nausea, vomiting, weakness, fatigue, and anemia. But of course, as with everything in nursing, it can't all be black and white. People might be totally asymptomatic with gastric cancer symptoms. They might not have them at all. Indigestion and belly discomfort is very potentially what you'll first hear people complain about. I just really want a quick talk about gastrectomies, so surgeries where the stomach is removed. A total gastrectomy with anastomosis of the esophagus to the jejunum is shown in this picture. So it's called an esophagojejunostomy, and this is the principal surgery for gastric cancer if we've got gastric cancer that can't be treated with any other manner. Gastrectomies are tough surgeries. They've got a lot of potential complications. Dumping syndrome is one of them. Early dumping syndrome is the rapid emptying of food contents into the small intestine, and that's going to quickly shift fluid into the gut and cause abdominal distension. Some of the symptoms include vertigo, tachycardia, syncope, sweating, pallor, and palpitations. Late dumping syndrome is believed to be caused by an excess release of insulin. Dumping syndrome can be prevented by eating small meals and eliminating liquids with meals. Also, educating your patients to have a low to moderate carbohydrate diet with a diet high in good fats and high in protein.